Great to be here. Hi, everybody. Reinhard, terrific talk. Learned a lot. And this is going to be a totally different talk. So we're going to go from 36,000 feet to a much lower place. And the talk's divided into 4 sections. I'm going to tell you 4 patient stories to start. I'm going to then briefly describe an initiative that's going on in Health Quality Ontario, where, as was mentioned, I'm the board chair, related to developing quality standards, just to let you know what's going on there. I'm going to use 3 slides from Helen Bevan, who's a sort of change management expert from the UK, because she gave a talk in Ontario a while ago that really resonated with me, and then I'm going to end with a few reflections. So David is a United Church minister. He lives in Marathon, which is a very small town on Lake Superior. You don't really see it that well with the screen, but he actually has a very large skin graft on his forehead there. He actually had a sarcoma that was misdiagnosed. He's had a number of surgeries on it. And here's one thing that he told me. There's a huge range in the quality of hospital care. Here's a suggestion for quality improvement questionnaires. Don't ask about how care was overall. I rated everything as medium, but it wasn't really medium. I had fantastic people for whom this was obviously their life vocation, and other people who I don't know what they were doing there. My nursing care was fantastic, and it was crappy. Some of the residents were unbelievably compassionate and careful, and others were just totally oblivious. The surgical residents and fellows, oh my gosh. I went back and forth between wanting to give them a slap in the side of the head and feeling sorry for them because they were so busy. My first post-surgical visit with the residents and the fellows, they came whipping in. There was about 5 of them. I was trying to have a pee. I had the bottle, and when they came in, I pulled the sheet up. They said, "How's it going?" I said, "Well, I'm having a little trouble peeing." I was about to explain when a resident yelled at the nurse to get me on some Flomax and put that catheter back in. And then they vanished. They'd pulled their gloves on as they came in, and they were pulling them off in the same movement as they left. There were 3 rubber gloves lying on top of me. I looked at Pearl, my wife, and I said, "Did that just happen?" And I should have said that I'm telling you these stories, and as I do, I want you to think about how you would improve the quality of care of these people in Alberta, and like what levers you have, what cultural changes do you need to make. So that's the reason for sharing some of these stories. Pat is a woman who lives in Toronto, and she took her mom home, who was dying from breast cancer, for the last 3 weeks of her mom's life. And her mom died at home with palliative care services. And she said, talking about a palliative care nurse, whenever she came over, the nurse seemed just as concerned about me and my daughter as about my mom. One day, she came out of my mom's bedroom, and we were sitting at my dining room table. She took 5 bottles of nail polish out of her bag and lined them up in front of me and said, "Choose a color." I kind of looked at her quizzically, and she said, I'm going to do your nails for you. You need to take care of yourself so you can be there for your mom." And she gave me a manicure and painted my nails. It was just phenomenal. I just couldn't believe it. So I still practice, and I practice as a palliative care doc. I'm actually starting on service on Tuesday. And I use this as an example in my house staff of patient-centered care. And I guess the question to you is, do you measure this stuff in Alberta? Is it important to measure it? And I am confident, and it wasn't just the nail polish, I'm confident that Pat is going to live the rest of her life actually thinking that the 3 weeks that she had her mom at home dying was actually a really good time. And what was it that made that quality so good? I'm going to give you 2 quotes from this next guy, who's Kevin. Kevin also lives in Marathon. A number of years ago, probably about 15 years ago, he was in a massive dirt bike accident, and he totally smashed the heck out of his shoulder. Needed a bunch of surgeries, and had chronic, severe post-operative pain. And he got put on opioids, became heavily addicted, ended up spending the next 10 years of his life homeless on the streets. And this is one of the things he said to me. I was so hooked on opioids. My doctor didn't know how to deal with me, so he kept prescribing and prescribing. He started giving me Demerol shots every 48 hours. I was on a fentanyl patch and swallowing hydromorphs at the same time. The nurses at the hospital started saying, this isn't right. So he stopped giving me those injections, but there was no going back. It was like something flipped in my brain. If it wasn't going into my arm, I was not happy. I would freak. I would go to the hospital and stomp my feet, and they would give me Ativan and all that. Over the years, it was a learned behavior. If I stomped my feet, I would get what I wanted. This went on for 10 solid years. I got all those drugs from the same doctor. He cared about me a lot, but he didn't know how to deal with me. I truly believe that he wanted to help me and just didn't know how. I've been struggling for a long time with anger towards him, but I've let it go. I just need to find, because it goes off the sheet here. Where was I? I've been struggling for a long time with anger towards him, but I have to let it go. I've accepted that I've played a big role in my addiction. There has to be a plan before starting opiates. For me, there was no plan. My doctor knew I was injured, and it was, we're going to put you on these. It wasn't like, you're going to go on them for 2 weeks and then we're going to assess. It was, here's 120 perks, and every month we'll be getting them. Once I started getting hooked, after 4 days, I'd gone through 120 perks. So instead of him saying, you got a problem, it was like, well, we're going to put you on oxys, and then we're going to put you on a patch, because if you're on a patch, you're not going to eat 100 pills a day. But even on the patch, I was still getting 120 perks for breakthrough pain and going for Demerol shots. Things kind of spiraled. I think he truly believed that he'd get me to a point where it would end, but that stuff often doesn't end. And then he says, I was finally ready to quit because I thought to myself, Jesus Christ, before I know it, I'm going to be 50 if I'm not dead. I'll be looking back at a whole life of nothing but abusing opiates. No matter how much I used, I felt terrible about myself. When you're shooting morphine, you shouldn't be crying. When you're crying, that's your first sign that this is not working. I wanted my life back. I knew that it would be up to me, but I would need some help. I got a new doctor, which was a miracle. I went to her and she said, listen, I went to her and I said, listen, I want to get off. I'm in pain from my shoulder, but I'm not in enough pain that I have to take 500 milligrams of morphine every day. She weaned me down, and I moved back to my parents' place. After I came off opiates, I had a massive psychosis and depression for a year. I wanted to put an axe through my head. I wanted to shoot myself in the head. It was so hard to describe. It was hell, man. So I guess the quality issue to me here is maybe this is an area where kind of guidelines of how you manage people that put on opioids, how you wean people off of opioids might make a difference. I'm also struck, though, that it's just an example of how two different docs can lead to two totally different outcomes in the same patient, and how he describes going repeatedly in the emergency department in this small town, so everybody knew he was addicted to opioids. And somehow the system just couldn't kind of make him see this new doc immediately and not sort of after he'd been on the street for 10 years. And then the final story is one of Bruce and Lynn. So you see Bruce in the background there. They live in a very isolated, quite simple cabin on the Ottawa River in the middle of nowhere. Bruce has end-stage COPD, and he was actually receiving home palliative care for COPD. This is where I interviewed them. And Lynn says, and they were poor. As best I could tell, both of them, their last two jobs were working at Tim Hortons. And she says, the government does not provide financial assistance to patients and caregivers who stay at home outside of covering medications and the visits from medical and support staff. But they're saving a fortune by keeping all these people at home. I'm caring for them full-time with no pay. I'm paying for food, for the mortgage, for the gas to pick up medications, for the hydro. And when you're running an oxygen machine 24/7, especially in Ontario, that really runs up your hydro bill. I'm in arrears with hydro. I'm like, you want me to pay it how? Nobody should have to be a full-time caregiver to someone they love. It's a horrid situation. The fact that the government doesn't provide you with the income to provide that care, that financial burden just adds to the stress you're already under. The paramedics, and to them by far the most important healthcare workers, they had a very good community paramedic program in this area. And when the guys and ladies, when they weren't on a call, they would go in and see them, check their O2 sats, et cetera. The paramedics are aware of my stress. When they leave, I walk them out, and they always ask, how you doing? Do you have any support? That's a problem. I don't. There's no support other than when they come. We really have no friends here. It's just us. And so there, I think maybe there's a policy intervention potentially outside of healthcare, like a minimum guaranteed income, that might actually address this. But there you go. So those are the 4 patient stories. Maybe to kind of, those of you that work in healthcare, you do realize that like healthcare is unbelievably complex. It's unbelievably diverse. And the thought that some policy on high is going to improve the quality of care of those folks, I think, is a little naive. I mean, like, you do need it, but you need some stuff down below. So let me switch to, I guess, a policy in the middle, which is an initiative that well, it's not an initiative, it's actually a major new initiative at Health Quality Ontario called Quality Standards, and really driven by the documentation. This is the only slide I'm going to show of variation, but incredible variation across the province in care, and variation that I actually find presenting data on variation to patients, to clinicians, and to managers. All of them, I kind of look at it and kind of go, that doesn't seem right. If there is a difference in the quality, if this variation reflects a difference in either quality or cost. And so the variation, actually I'm not going to show you the guidance on hysterectomies for uterine bleeding is just being developed, but here's looking at the regions in Ontario. The gray bar is hysterectomies for cancer, not that much variation. Hysterectomies for heavy menstrual bleeding, huge variation. So the variation in care is really the impetus for the standards. And so the characteristics of these quality standards are and we at the board have had a bit of a discussion about whether 5 to 15 statements is really concise. Some board members think it's not, but the guidelines for the Canadian Diabetes Association has probably got like 150, 100, or 200 guidelines in them, right? So 5 to 15 quality statements. Saying to patients, if you have this is what you should expect. We hope they're accessible, easy for clinicians and patients to see what high quality care looks like. They're measurable. Well, this is different from a guideline. So every standard, for every statement in the standard, has a suggestion about how clinicians or the system could measure that standard. They're implementable, so there'll be associated quality improvement tools and resources associated with each quality standard. And just like clinical practice, they're not absolutist. And these standards are developed by a quality standards, it's called an advisory committee, but in all honesty, I think it's the quality, they actually, with the support of HQO staff, developed the standard. And I looked at the Quality Advisory Committee for the standard on, we've released 3 standards so far, on the management of major depression. And of the 19 people on that committee, 9 of them were clinicians. And by clinicians, I mean that broadly, occupational therapists, et cetera, not just docs. But 9 of them were clinicians. 5 of them were directors or managers within the healthcare system. They actually worked in, a clinic or whatever, providing care. 3 of them were patients. 2 of them were researchers, and none of them were from the Ministry of Health. So this is very much an attempt to be a fairly clinician, patient-driven. This is kind of what quality of care should look like. Obviously the writing is small, but here's the major depression. There's a series of standards from, what should you expect when you're initially assessed. There's a standard on if you're not doing well, maybe you actually, if you're really not doing well, maybe you need to think about electric convulsive therapy. It gets fairly granular, and they're fairly broad. And this slide didn't actually, I should say that I got these slides from Irfan Dalla at Health Quality Ontario, and I thank Irfan. But just to make the point that for every statement, and here, this is one on the management of people with dementia who have severe behavioral problems. And statement number 3 is basically before you put someone on antipsychotics, try something else first. And the definitions are definitions of what those something else might be, music therapy, etc. The indicators, what you might use as a process indicator or a structural indicator to see whether you're doing well or not. And the audience statement, and the audience statement for the patients basically says, before you go on some drugs, you should expect that something else has been tried. And for every one of these, there's a patient reference guide that's 3 to 5 pages, which actually is focused on the patient to say, if you have this particular disorder, these are the things you should be thinking about, and this is kind of what you should expect. And so here are the 3 that have been released are at the top there, and this just gives you a sense of the ones that are coming out. As a board, we've really pushed to try and make as many of these as we can, sort of primary care or transitions of care. The first couple, I think because actually they came from the ministry as topics, are, schizophrenia was in hospital, but you'll see at the bottom there's a schizophrenia care for people in the community. So our sense is that we probably need these more, at least in Ontario, in the primary care sector than in the hospital sector. And what these quality standards mean to our key audiences, first and foremost, patients, caregivers, and the public. We hope it'll help them understand what excellent care would look like and what they should expect. Healthcare professionals, I'm looking forward to the one as a practicing palliative care doc. I'm palliative care, and I plan to look at it and say, okay, in the hospital where I work and the group I work, like, how are we doing here? Provider organizations, so if one of the standards is in a long-term care facility with agitated, demented people, you should be able to provide a bunch of therapies other than drugs. You got to see, do you have a music therapist on your staff? So there's things that would be relevant to the providers. The LINs, which would be your regions, and other agencies can also use these to, if you will, hold the practitioners accountable. And the government can certainly feed into the priorities or into the standards, saying we'd like you to consider making a standard in this area because we think it's a big issue, but can also use it for performance measurement. So early days, but these 3 standards are up on HQO's website. The other thing I should have said is that the draft standards are always available for patient and public input. So they're posted on the site. And then said, please send us information, and then the quality standards committee then takes that into account and decides whether they should change them or not. So this is a segue to Helen Bevan, who visited Ontario a while ago. And I'm kind of I used to be the CEO of the Institute for Clinical Evaluative Sciences. I'm a health services researcher. I like numbers. I focus on measurement. It's one of the things I was really interested in when I was on the board of Alberta Health Services. But there's to make change, you need a lot more than that, and that seems kind of obvious. But sometimes in groups like this, I think we don't address that explicitly enough. And Helen started by saying, really, if you were to look at what happens to large-scale initiatives in healthcare, really. And by large scale, I don't mean just at a provincial level. Like in a hospital, a large-scale intervention might look totally different, but it's large for that hospital. I mean, probably what usually happens is the effort effectively runs out of energy and simply fades away. Or there's improvement initially, and then it kind of peters out. And unfortunately, I think the least frequent outcome is the one that we really want, which is that you get substantial lasting change. And so she and her group, and this is beyond my area of expertise, have looked at what are the things that have made those changes successful. And she's come up with what she calls 5 energies. And most of us, certainly me in my room as an academic physician and researcher, I'm sort of at the intellectual one. Like, what are we measuring? Like just what Ryan, how do we define this? Blah, blah, blah. I mean, not blah, 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 blah. But she makes a point that to affect change, you need a lot of other stuff. And I would say that most of that other stuff has got to come from the bottom up rather than be imposed from the top down. And here are just her definitions of the 5 energies. So, social, personal engagement and connections with people. You got to you have to have engagement with the people that you're working with on this. Spiritual, commitment to a common vision for the future driven by shared values and a common purpose. psychological courage, resilience, and feeling safe to do things differently. And she did say, actually, that Google had done a thing, and they thought that in making major change, psychological energy was the most important. And if I think at my hospital, which I love, I've been at St. Michael's for longer than I've been at any other healthcare institution in my career. But man, there are and this is all about a safe space. And we talk about quality improvement. You got to be willing to acknowledge when things aren't going well. Even at a place that I think people get along well with, there's a real reluctance to sort of say in front of some senior management, you know what, we tried that and it didn't work. You gotta have a safe place, and that's a cultural, that's a cultural thing. Shoot, am I gonna be able to go back? Yeah. Physical, like just getting things done, not just going into a meeting and then sort of forgetting about it and then going back again 2 months later. And then finally, the one that actually I'm living in actually is the intellectual, and my own bias is many of us involved in sort of administering and running the healthcare system. If you look at this, at least me, I spend more time in the intellectual space than I should compared to the others, or at least think of what did I think of as a board member at Alberta Health Services. I spent a lot of time thinking about what are the metrics, the kind of thing that Reinhardt, I spent a lot of time thinking about, like, you know, how engaged do the workers feel? Yeah, we did, but not as much as I should have. And so she makes the point that this is what happens when the energies are high and what happens when they're low. So sort of final thoughts from someone who really isn't a quality guru, but of observer. So, you know, the reason for showing those 4 stories, aside from the fact that that's why we're all here, is that clinical care is exceptionally varied. Most of it actually happens in the home in primary care or transitions. So I think that's got important implications for how we deal with quality. And also just, to me, to really make a change in quality across the system, the other 4 energies that Helen were talking about are really, really incredibly important. You know, improving quality is tough. And to the point about how Health Quality Ontario standards need to be implemented, you know, some of the standards are going to need to be implemented at a higher level, a policy level, and some are very much at the ground, very different approaches. I never thought I'd say this, but we'll never be able to measure all the things that are important, and if we did, we'd have no time to do anything else. So we just need to be careful about what we measure. I do think we could kind of go crazy on this. And beware of unintended consequences of measurement. In Ontario, we say, and I believe strongly, that a woman with an average risk of breast cancer who's 50 to 70, it's kind of up to her values about whether she wants a mammography or not. Cancer Care Ontario's website publishes the percentage of women that have mammography as if the higher it is, the better. And I think, Rick, some family docs are still paid more the higher the rate of mammography. So, like, to me, that measurement outcome and what we're really saying are very, very different. And that measurement outcome could actually drive what I would say is inappropriate behavior, at least when I talk to my wife about what her family doctor talked to her about, whether she should have a mammogram or not. She should just have the damn thing. Non-intellectual energies are very important, tend to be neglected by people like me, and I think are more likely to be achieved locally than centrally. One thing that Health Quality Ontario has done, and we haven't really evaluated it, but I just intrinsically like, and you know, with the position of IHE here, is for the last 2 to 3 years, we've been training sort of a cadre of quality ambassadors. There's a program, sort of a master's program, I think, actually, called Improving and Driving Excellence Across Sectors. So at our hospital, we have 4 or 5 people. Like, I never got trained in quality, and most of us in healthcare who are at the front line haven't been trained in quality. It's probably different than the Mayo Clinic. And it's just really important to have some local people who are passionate about this, who can really do stuff at the ground level. And when you see these people get together, there's just an incredible amount of energy. It'd be a terrific thing you folks could do with Lethbridge, and so the Institute of Health Policy Management Evaluation is involved with this. ISIS, I shouldn't say ISIS anymore, Institute for Clinical Evaluative Sciences, et cetera. I just want to raise the concept of joy and work. My understanding is that IHI is now talking about 4 aims. And the 4th, I think this might be job satisfaction, but they've called it joy at work. And I think they're right to recognize unless people really want to go to work each day and are really committed and passionate about what they're doing, it ain't going to happen. So I think actually this is an important thing for us to recognize. I really do think that leadership by clinicians and patients is just crucial. It's interesting, I hope Stephen Duckett won't mind me saying this, but after he was here for 6 months, I remember saying to him, Stephen, like, what's the sort of best thing about Alberta that you didn't think, would be so great, and what's sort of the worst thing? And around the latter, he actually said, and this is a health economist talking, he said, I'm just really surprised by how little docs are involved in managing the system and doing it. I thought that was a really interesting comment. And finally, the older I get, the less I think I know what I'm talking about. So thanks very much.